Right. It's 12:01. We've got a ton of stuff to speak about today, and I've been asked to keep us on track. So I'm gonna get us rolling with today's webinar. Hi everyone, and thanks for joining us. I'm sure there are going to be a lot of additional people rolling in over the next few minutes. We've got a really interesting discussion today on rethinking home care. My name's Dan Carbin. I'm a managing partner at Santis Health. For those of you who don't know us, Santis is a Canadian healthcare consultancy that's really full of people who care passionately about driving change in the healthcare system. We try and bring together policy wonks who are interested in the what needs to change with those who are expert in how to drive change, so we can actually see the change happen that we think needs to happen in the Canadian healthcare system. We're really privileged to be hosting this webinar today. We think it's going to be a fantastic discussion. Before we get underway with the discussion, though, I'd like to acknowledge that while we have people joining this session from across Canada, I'm currently located in Toronto, which under Indigenous custom has long been recognized as part of the broader dish with one spoon territory. The dish with one spoon approach to peacefully and sustainably sharing land and resources governed Indigenous relations in this community for almost 1,000 years and was codified into formal treaties between Indigenous groups and later settler communities. The core underlying philosophy of the dish with one spoon is that all of us who call this land home have a shared responsibility to protect the land and pass on a sustainable future to those who come after us. We have a responsibility not just to each other, but to the future generations who will take on stewardship of the land when we're gone. And I'm hoping we can keep these sentiments in mind today as we talk about how to improve Canada's home care system. This is obviously tough work, with lots of complexity and lots of things that could go wrong along the journey. But if we get it right, we'll be leaving a legacy of improvement, not just for those people who need home care now or in 5 years, but for future generations who will also want to live independently at home and in their communities for as long as possible. Our healthcare system is obviously facing a lot of challenges coming out of the pandemic. Several years of missed or delayed treatment combined with the health impacts of the pandemic and the pandemic response have led to a surge in demand for both physical and mental health care. This is a surge that the public system has struggled to keep up with, especially given the parallel epidemic of burnout confronting frontline healthcare providers. While a lot of the initial public and government attention focused understandably on how we could stabilize acute and institutional care, as we gain a bit more distance from the pandemic, it's clear that we need to take a step back and take a more systematic and longer term approach that's going to reorient our system to deal with the growing demands of our aging population. Rethinking the role of home and community care is central to this paradigm shift. We have a great group of experts on the panel today that I hope can help us imagine how home and community care can change over the next decade and offer Canadians better opportunities to remain at home with as much independence as possible. But just as importantly, we're going to try and unpack some of the barriers that have impeded significant transformation over the past several decades and share some thoughts about how we can do things differently this time. How can we successfully implement the change that so many people have been calling for so many years? Before we kick off the discussion, I wanted to first let Diana Gazdar from Medline Canada, who sponsored this webinar, to say a few words. So over to you, Diana.
Thank you, Dan. We all know that getting older is an inevitable part of life, yet Canada is not adequately prepared to grapple with our aging population. And so I hope that today's conversation is both thought-provoking as well as solutions-driven. This is the second Santis Health webinar that Medline Canada has sponsored this year, and we are excited to bring together another fantastic slate of panelists to discuss solutions to some of the most pressing challenges facing Canada's healthcare system. By bringing subject matter experts to the table, we can spark new ideas, innovation, and discuss shared goals. It's why at Medline, we value coming together to improve care. While Medline is one of the leading manufacturers and distributors of medical products in Canada and all around the world, we don't just provide supplies, we believe in building partnerships to provide solutions. Our team has decades and decades of practical clinical experience that we are bringing to the table to do just that. We know that conversations like the one we're going to have today are so important. They give us the opportunity to share knowledge, to strengthen our mindsets, and to make us all better. So without further ado, I thank you all for attending today's webinar. I'll pass things back to Dan.
Thanks, Diana, and thanks to my fellow panelists who pointed out that many of you could only see the top of my head. I hope I've adjusted my camera so that it looks a little better now. Before we get rolling with the discussion, I'm going to give each of the panelists a minute to introduce themselves. Full bios were sent out with a link so you can see the full bio, but I wanted to let them introduce themselves in their own words. So I'm going to start with Laura. Over to you.
Thanks, Dan. My name is Laura Tamblyn-Watts. I'm the CEO of CanAge, which is Canada's national seniors advocacy organization. I'm also a professor at the University of Toronto. Today, I'm joining you from rural Nova Scotia.
Thanks, Laura. Deborah?
Hi, good morning, everyone. I'm Deborah Simon. I'm the CEO of the Ontario Community Support Association. We represent about 220 not-for-profit home community care organizations across the province of Ontario, and I'm here in Toronto. Thanks for having me.
Thanks, Deborah. Connie?
Good afternoon, everyone. And I'm Connie Clerici, the Executive Chair of the Board of Closing the Gap and the founder. It's such a pleasure to be here today, and I look forward to the conversation.
Thanks all. And with that, we'll get the conversation rolling. I just wanted to remind people that are participating in the webinar today that at the end of the session, we're leaving about 10 or 15 minutes for audience Q&As. So if there's something you'd like to ask, you don't have to hold on to it to the end. You can bang it into the Q&A and we'll collate those and ask at the end of the session and make sure we get some of those really important questions out there. And with that, I'm going to get things rolling. So we're going to start the conversation with a bit of a level set and an assessment of where Canada's home care system is today as we come out of the pandemic. Now, there's been a lot of talk for a number of years about the shifting care to the home. Big focus of the last health accord discussion was investing in home care. The premiers met just 2 weeks ago talking about the need for more investment in home care. The question is, what is the starting point that we're dealing with now in 2023 that we're using as the baseline for future progress? So I'm going to ask Deborah to share her perspective from Ontario, and then we're going to kind of open it up.
Right, thanks, Dan, very much. And sure, for sure in Ontario, where I reside, that we've started to see the ball moving. Certainly, Ontario has identified the importance of moving towards home care modernization, term that they use here, in terms of both policy and process for the services that are delivered across the province. Part of this modernization is to look at opening up home and community care services to be part of a more integrated approach to care. And so we're starting to see that happen. Obviously, the pandemic did put a big halt on things for the last 3 years, but we're now starting to see some further advancement of some of the projects around home and community care. We're starting to see many of the OHTs that are in a greater state of maturity starting to look at home and community care services. But we're only at the beginning, and I think it's a long journey ahead of us, certainly. But we do see the ball moving forward.
Thanks. Connie, you're Closing the Gap operates in Ontario and Nova Scotia. Would you kind of share that assessment that in Ontario, you're on the cusp of change with all these pieces lined up? And then how do you see things playing out across the rest of the country?
Well, certainly, I think we're in a very exciting time where we're faced with significant challenges in healthcare. We have the opportunity collectively to create a truly integrated health system across every province, and making sure that it's integrated and equitable, not only in using our words, but using our actions that would benefit both patients and the staff that we serve. I think it is imperative that we all embrace the learnings from COVID. It was a challenging time, but also an exciting time where we saw new levels of collaboration and innovation and communication. So I think that together we can do this. It is time for change, and it is time for us to be ready and to respond to the changing demographics instead of being reactive.
Thanks. Laura, do you have something to add on this?
Across the country, we have the same calls, right? Everyone wants care at home. And many people believe that it's going to be easier than it actually is when you actually get to the point where you really need home care, or you're trying to allocate home care. If you're in a system or you're trying to figure out how to actually do it, the challenges are pretty profound. What we've seen, however, is different provinces react in different ways. And all of this is generated by some excitement of federal transfer. Certainly the last couple of weeks, as you say, we've had a refresh of conversations, but folks should turn their mind back. 2017, we had $11 billion from the federal government allocate to the provinces for both a combination of mental health and home and community care. And what we have not seen really is that money get dispersed in a way that's made a big change. So we're coming at it with some real challenges, but also with a diversity of responses from different provinces.
Yeah, it almost seems like we're having to hit the restart button a bit from that 2017 conversation due to the break from the pandemic. The major difference being, of course, the population is significantly older than it was in 2017. So those challenges are amplified, and the need for action is even greater. If Laura, if you turn your attention to, so you reflected back on 2017, that's 6 years ago, with not a huge amount that's changed in the system since then. If we're looking out to the horizon, say 10 years out, further aging of the population, more 85 plus people that are going to be dependent on healthcare services in the home and in community and institutional care. What is realistic for a vision for home and community care to have changed within that 10-year horizon? What does it look like? How is it different?
So I think that 10-year horizon is a really important one, but let me even just take 7 years. So in 7 years, we've got the boomers turning 85, we've got Gen Xers like me turning 65, we've got millennials turning 50. Just take a breath and realize like what that's going to mean. And our over 100s are tripling, and by that point, maybe even quadrupling. So that's in 7 years. We actually have to really get our heads around 7 to 10 to 15 years forward. Look, we're not going to have enough people. Like, that's just the reality of a circumstance. So home and community care is going to have to be really crisp in what it's actually doing. We're going to need more medicalized home and community care services. So that means people coming to the home to provide not quite acute care, but subacute care. And already that's happening. So people are actually getting treatment in the home. That's good. We want that. We want them out of acute care where people need to get their legs reset from breaks or to be there for surgery. So like, that's just the reality of a circumstance. But what we don't have is staff necessarily in the homes with that degree of medicalized knowledge. So we need to upskill into more nursing care. And at the same point, we need to build capacity around that more housekeeping type of services where we really don't have anything. A lot of the times, people don't really need to be moving into congregate care settings. They need someone to rake and move the snow off of the bricks, and they need to do shopping. In urban settings, the rural-urban divide is going to be more acute. It's going to be easier in urban settings, and particularly since we have services that are more app-based services to help. In rural settings, where already 65% of the population is over 65 now, we're going to see a big rural divide. It's going to be much harder to get home care into those services.
Connie, from the perspective of someone who runs an organization that delivers care in many of these diverse environments, how are you planning for that change? How would your organization be fundamentally different in how it thinks about meeting that care need 10 years from now, or even 7 years now, if that's more manageable?
Well, I think what we would like to see first is home care to be acknowledged, home and community care, sorry, Deborah, as a valuable part of the health system, not just a silo that's off on its own. So it would be very exciting to see all providers acknowledge that we need a systems approach. So what Closing the Gap can be doing, and what we're trying to do, is to introduce innovations where clinicians and patients make all the decisions. There isn't a prescribed formula that meets the needs of everyone. We must be able to, it's almost going backwards to when patients and their direct care providers decided what was best for a family and a patient at any given time. In order for us to do that, I think across all of the country, we need to revive the relationships between acute care, home care, long-term care, community support services, and primary care. We all must be able to collaborate and communicate with one another in order to be able to provide the best possible care. Currently, we have a lot of breaks along the way, or a lot of barriers. And we need to acknowledge those and remove them.
Thanks, Connie. Deborah, in Laura's comment, she talked about the diversity of need that home needs to be addressed in home and community care, ranging from the more medicalized end of the spectrum right through to homekeeping and more traditional community supports. Can you talk about a little bit about how you see that broader continuum evolving? And to Connie's point, how is that more effectively integrated within the rest of the healthcare system instead of being operated in strict silos that keeps it apart from, even keeps home and community care apart?
Yeah, thanks for that. And you're quite correct. And I think just for the audience, the context of home and community care in Ontario is such that home care and community support services are funded differently and administered differently, which makes it really challenging, because I think the real value of home and community care is when the two can leverage each other, that we can wrap around services for clients as they need it, not just the professional services that come with professional nursing, physio, but also the kinds of services that Laura was talking about, like the shoveling, like the meals, like support and respite for caregivers. And I think that is all embedded in the community, has been for decades, through community support services, community mental health services, those kinds of things. So as we're sort of looking at the future of home and community care, I think, you know, my formula for success will be that we actually take a home first, community first approach and thinking when we're talking about that huge group of people that Laura so clearly identified, which is just overwhelming when you think about it, and start thinking about first how we can triage to allow people to stay in the communities in the best way they can. And so many of our seniors really don't need the full gambit of home and community services. They just need light supports like homemaking and other and meal delivery and all those other determinants of health that really keep people independent in the community. And also the supports for services like exercise and physio, which will actually prevent the hospital admissions that we're all trying not to see happen with community. Sorry, with care from hospital and acute care. I've been working on a working group that's been looking at sort of the alternatives to building beds in this province, and I know our government is really looked at looking at more long-term care beds. Clearly, there's a need for some long-term care beds in some communities, but there are many programs, and they're not just subacute programs. They're acute care programs like high-intensity care for seniors that really provides an intensive level of care that rivals hospital care in some cases, to allow people to continue to stay in the communities. Also really working towards, and this will come with Ontario health teams for sure, more team-based integrated care, the need for a strong tie-in with primary care, with home and community care, so those services are continuous and sustainable. And lastly, I'll just touch on the upstream services that we just talked about. Community support has been, I think, the best kept secret in this province, and it shouldn't be a best kept secret. Meals, supportive housing, transportation, friendly visiting, respite, just to name some of those services that are really going to keep all of those folks that don't need to be in long-term care in their homes and in their communities, and thriving are really critical, I think, to the future.
Thanks for that, Deborah. As you're talking about a lot of these changes that need to happen, it echoes a lot of what's been talked about in health policy circles for decades in some form or another. I was in the Ontario government in 2007 when we rolled out, at the time, the Aging at Home program, $1.2 billion committed over 4 years. It was supposed to support some of that change that you've talked about in driving a more supportive community sector that would take the pressure off institutional care needs. Every Ministry of Finance across the country knows that they can't build enough long-term care beds to meet the needs of that population growth that Laura talked about in the super aging population. Yet we've still not really had the fundamental change in home and community care that you kind of expect would be necessary when you look at those projections. Can you give your assessment, why it's been, and I'll go to each of the other panelists too, why has it been so hard to drive change in Canada? Laura talked about there are changes happening in some provinces and at different speeds, but overall, why has it been so hard to realize that vision that you talked about that there seems to be broad consensus around?
Yeah, I think, for decision makers, Dan, I think, we are very caught up with institutional care. It's, it is contained, you could see it, you could feel it. The data often, is there to help decision makers, fund programs that are generally acute care in nature. The challenge is that, it has been a small component and not seen really component of community that has had programs in place for decades, but they are invisible to most folks unless they actually need them. There may be a tad of ageism in there as well, because most of the programs in the community have really been derived for seniors. And so, again, the programs are really not applicable across the board. But I do think, in order to move these forward, we need to take the approach that other jurisdictions have had, which really starts with community and says, what can we do first at that level before we actually look to long-term care and acute care for those supports. And, there are so many great examples of it and to be able to help us model our care here in Ontario.
Connie, I'll give you the same question. I know you spent a lot of your time recently trying to influence, advise on government policy, support the kind of change that you believe in. What's your assessment of what those barriers are to driving that kind of home and community first kind of mentality across the healthcare system?
Well, I guess my first comment would be that it's a value statement. And having been in home care for most of my career, home care used to be Monday to Friday, 9 to 5 kind of job. And I don't think people have moved past that to see how the acuity levels are so high and how we have to bring all supports together to be able to keep people at home. One of the barriers that it has astounded me for a very long time is that every time changes is introduced, or even just the discussion around change starts to happen, people take it as an insult. And that from my perspective, change is not an insult. It doesn't mean you did things poorly in the past. What it means is we're evolving as a society in order to do things better. I honestly believe that all practitioners get up every day with the best of intentions to do the best that they can for the people that we serve. And again, just to share a thought that I have is in home care, we know every time we walk into someone's home to provide some level of support or care, that we're their guest. They don't have to put up with this. They can ask us to leave, which is different in an institutional setting. We also have to acknowledge that people have a right to live at risk. And sometimes that's a barrier for the patients accessing care. So, again, I think we just have to change our attitude when it comes to change management and how we move forward. And just my final selfish comment that I always say to everybody is, now we're screwing around with my healthcare because I'm over the age of 60. So I used to say that when I was 30, but now it's real. We have to make sure that we give people the opportunity to live at home independently with their dignity, and living the way that they want to live, not the way that they would live if they were in a facility.
Laura, do you have thoughts on, I mean, you referenced the 2017 commitment and all of that funding, where it's easy to get up and make an announcement that you're going to change home care or invest significantly in home care. It doesn't always flow through. So what's your take on that in terms of the barriers to drive change?
I think there's three things, and I'm going to call out ageism, just building on my colleagues' piece there. It's really important to remember the narratives that we have around care, and we never saw those narratives more starkly than during the pandemic. So everyone who was working in acute care, we banged pots and pans and we said how great they were, and that's absolutely true. There's no question about that. The narrative around long-term care was as opposite as you could possibly imagine. And remember, people were working with incredible challenges at the time, but the narrative was, this is the worst thing in the world. The people working here are abusive and so on. And of course, that wasn't in many cases the case. And certainly it was very focused on a couple of key provinces and not necessarily the experience across the country. And then where was the narrative of home care? Oh, wait. There was no narrative of home care. It actually disappeared, right? And for most people, they couldn't actually get home care anymore. It actually stopped in many jurisdictions. Not in all jurisdictions, but in many jurisdictions, people just said, we can't actually come to your home anymore because of restrictions. So there was zero conversation about home care. And it's interesting because home care is the one that touches most people. It's not so much hospitals. Those are very few people that touch the hospital space. And when we're thinking about our care and long-term care, again, it's a very small percentage. 5% across the country of people will ever live in long-term care with an average of something like 18 months as the length. So everyone else is getting home care, and yet we heard nothing about it. So there is an ageism piece and a lack of visibility that's there. There's a sense that it's kind of an optional kind of care, or that you're lucky to have it. And I really think we need to challenge that notion, that someone is going to kind of gift you a kind of care. So first of all, it's nonsense. We've been paying into our taxes and this is part of the care. But we also do make it that it's only really if you can afford the care. Let's call out what it costs for 24-hour home care. If you were really saying, ideally, I'm going to have someone take care of me in my home for 24 hours, and I'll use the provinces of Ontario as an example. $100,000 to $300,000 a year is what you're looking at. And it's going to be much more like the $300,000 than it is the $100,000. And those numbers aren't so different in other provinces as well. It's completely unaffordable. So then the last piece is, how are we paying people? So we have this huge need. We have this ageist narrative that, you don't want to take care of older people in their own homes. It's not kind of the cool and sexy thing. And actually that's true, because we don't pay people well who do it. It turns out if you give people the right tools, the right job, the right dignity, the right care, and we pay for staff to do work, not where the work is done, you can actually build a very good system. And we know this is good because we see it in other countries. And we have to stop pointing to our Nordic countries and actually just do what they do. It's less expensive and it's more effective, but it does mean we need to push back those ageist narratives. And it does mean we need to pay people for the work they're doing, not the location that they're doing the work.
Yeah, you pulled on a couple of really interesting and important threads there. I mean, home care is not part of the Core Canada Health Act. It's something that has grown up organically across the country in response to the needs of the population, but there's no kind of defined benefit of what the public pays for across the country. It's different from community to community, even within provinces. It is managed and overseen very differently than the rest of the healthcare system, with a lot of the staff across the country not having access to full-time positions, not universal access to pension or strong benefits. the providers or that are delivering the service paid in a fee-for-service basis that many of them tell me impedes innovation. Connie, can you maybe respond to, I've had conversations with you and colleagues in the past saying, we would like to deliver care differently. We would like to work with the system differently, but the system doesn't treat us in a way or pay for us in a way that allows us to innovate or allows us to put those client needs really first. We're paid on we're paid for delivering units of time, essentially.
Yes, and a great conversation and very near and dear to my heart. And the episode of care model does not provide us with the opportunity to plan effectively. We don't know whether the referrals are coming in. There's so many variables and ebbs and flows in care. And we don't have any redundancy built in our home care system. And when I say that, I'll just give you an example that I use quite frequently. When I was an intensive care nurse, I worked in the hospital. It was a 6-bed ward. And when I would go to work, there were 2 ICU nurses there. And if there were only 2 patients, they didn't send one of us home and take our paycheck away. And that's essentially what we are expecting the workforce in home care to deal with. Is in the episode of care model, the only funding we get is when the care is delivered. So if a patient gets admitted to hospital, that clinician's wage is cut off, as is the organization's support for infrastructure. It's not a good model for building HR capacity, but it's not a good model as well to deal with the ebbs and flows. So you may have, 50 referrals, I'm just picking numbers out of the sky today, but only 20 tomorrow. So what do? Do you lay off 3/5 of your workforce for a day? That's essentially what the expectations are. So I believe for a properly functioning home care system, we need to be funded either through an episode of care model or using full-time equivalents with part-time and casual. At Closing the Gap, we were very fortunate. We made the decision decades ago to provide pensions and benefits to our workforce, and we've reaped the benefits from that. We have many employees that are retiring with us, and that's a completely different model than when people feel that their paycheck is at risk. They have no choice but to work for 3 or 4 or 5 different service providers. So I think it's an enormous issue, and it really has to go back to building in some redundancy within the system. And if you don't have any patients to see, maybe we send the nurse to or clinician or PSW, maybe we send them to long-term care or acute care for the day to help with their capacity challenges. I know there's a solution. I know everybody's bright enough to work together to figure this one out. And this one is a definite must as we go forward with trying to create an integrated model. Thanks.
Thanks.
Dan, can I just speak to Laura's comments? Because I know that Laura wasn't inferring with home and community care that you need to have 24-hour round-the-clock services, not at all. And there are so many really creative and innovative models and new technologies, quite frankly, that allow people to continue to be in their homes, in the community, with access, quick access to services that they need or professionals that they need when they need it. Hub and spoke models that have been, providing care to people in supportive housing in their communities. There are, home-based technologies now that are just phenomenal, that allow people to feel the connectivity to their providers without necessarily having somebody physically in their home. And we know many people don't want to have a barrage of individuals in and out of their home. It isn't hospital in the home, it's home and the care that they require while they're in those settings. So I do think, again, what's the detriment to home and community care? We are silent. We are an uninsured, guaranteed insured program through, our federal funding, and it shouldn't be thought of as a gift or an you're lucky if you get it. I use that statement around the best kept secret, and the way to say that we need to take that and shine a light on why we can provide these kinds of services here in Ontario and across Canada in a way that is efficient, effective, and meets the demands of what Canadians want in this country around their care.
Deborah, can I just ask you a follow-up question? You talked in your opening about Ontario being on the cusp of reigniting its home care modernization journey. There's a lot of talk about activity that's going to happen in the fall with structural change. When you talk about those advancements and innovations around things like remote monitoring, the use of virtual visits, the adoption of technology, what I hear from a lot of the publicly funded providers is there's no market in doing that for them. They can't get funded to do it. So as a province like Ontario, and we've got this acute human resources crisis, as they're shifting the model of care in provinces like Ontario, how can governments think about how to fund, pay for, and hold home care providers accountable in a way that gives you the freedom to provide that service to individuals who need it?
Great question. And you're right, there has been very limited investments in virtual and digital for providers. And certainly we are really pushing hard from an advocacy perspective to get attention to this, because I think these IT information technology approaches are only going to enhance what is already a great service and provide much more just needed services in terms of, particularly while we have these labor issues that we're trying to address. But I think there are more opportunities, Dan, now to do some exploration of that. But the funding, again, for providers, because of what Connie talked about, the fee-for-service approach, and we haven't hit yet the opportunity to show and demonstrate innovation in home and community care because there isn't allowance for that through the funding. So we're starting to see a little bit of movement on this, for some calls for innovative models, and we're starting to see some opportunities for that. But I'm still going back to Laura's comment about the barrage of folks that are going to need this services and how soon and how long we can wait for this to happen if we don't actually take action immediately to try and move home and community care up the totem pole as the #1 approach to healthcare in this province and in this country.
Yeah, my kind of assessment, and others may or may not share this from my time in government and out, was that government manages home care in a very, very risk-averse manner. And the two risks that they're primarily focused on is, one, first, do no harm to the people that are currently dependent on home care. So let's not disrupt any service delivery as it exists today, which is understandable. The second is a fear of financial risk, which is if we open the floodgates, this service is just going to explode. We're not going to be able to afford it. And if we don't pay on a rationed fee-for-service model, we're really, the providers are going to determine more the needs of the clients, or the clients and their families are going to determine need, not the government. And that's going to really open the floodgates, and we can't pay for it. So that trying to manage that risk on the clinical or on the delivery side and the financial side has kind of locked things up for in terms of major change. Does anyone have any thoughts on how we can address that risk?
I do. I just want to make a comment. I know Laura probably has a comment, but I think that the concern around consumers driving up the cost because they're going to run the government, drain their pockets because of their overuse of the system is just nonsense. There's a program called the SMILE program. I think it's probably in Nova Scotia, where it is more of a self-payment model, self-directed model, where individuals are basically given the funds to be able to choose the services that they need. And evidence definitely shows that people underspend in that because they're much more practical in terms of their use of those services and what they bringing in just what they need, not necessarily the whole barrage of services that are out there. So I think that the fear is unfounded, as is the fear of and the risk. We have many providers, particularly in independent living circumstances. So individuals who have physical disabilities, living to the maximum ability that they can, with some supports from attendants that allow them to continue to have independence in the community. And there's a lot of individuals who choose to live with what is an institutional type risk settings, and they are happy and they are safe. So I do think that a lot of what you've raised is some of the thinking by decision makers, but it is really unnecessary and unfounded.
I think Ontario can really start looking outside of its borders, actually. Like Ontario's got itself locked up in a place and believes, I think, in some ways that nobody else exists. And the reality of the circumstance is we're actually doing it much better in many other provinces. God forbid that we actually say that things can be better in other places. Alberta has taken this on really concretely. Step one, they changed all their legislation in 2022. They got rid of separate legislation, and they have one particular bill, Bill 11, that went through, which now, astonishingly, puts all of care in one piece of legislation. So whether it's home and community care, whether it's up in that house and housing continuum, right up to long-term care is under one piece of legislation. That completely explodes a lot of the blockages that we have in Ontario, where all of these things are legislated in different ways. It also means that the regulation is then much more seamless. The reliance on home and community care together, but funded separately, is not being done in a bunch of maritime provinces. New Brunswick, for instance, is looking at it in a much more engaged way, because they're actually saying that if you have these kind of community-based organizations that are living grant to grant or year to year, often when their agreements aren't being funded for, in some cases, months at a time, and they're trying to struggle through, those are not reliable based services. So let's actually integrate the funding, as Deborah was saying is a challenge in Ontario. Let's integrate the funding to make sure that these community-based projects aren't just a nice to have, but they're actually a concrete part of it. And then let's think about how things are being done with unions. We haven't talked about unions, and it's a huge conversations we need to have. So BC 20 years ago invested in one big union upswing, and as a result, they have much better paid folks. They have much more reliable benefits and services, and their unions are much more of a bargaining partner in a coalesced fashion than we see in other jurisdictions. So we can't forget that that big gulp 20 years ago was hard, but it has streamlined the conversation in that province.
Thanks for bringing that national perspective. Connie, do you want to add to this piece of the conversation?
Sure, and thank you. So what I would like to say is I find that typically people don't even know what home and community care is until they need us. And so as much as Deborah says that community support services are the best kept secret, I think home and community care is the best kept secret. And that's when people call me for advice and how do you get through this? But I also am concerned that if we continue on the trajectory that we are, that we're really supporting and nurturing a false economy. And I say that because if we all take a look at the newspaper from the weekend, I think we can see that changes in the air. And for all staff, this should come to be the number one issue that we deal with, because with the ONA arbitration report and the massive increases that acute care is getting and has continued to get, the disparity between acute care and home care and long-term care is growing and growing. And I think we need to be wise and say pretty soon we're just not going to have any home care. Nobody's going to want to work there for what would be considered with these rate increases is poverty wages. That takes me back to what I said previously. People think community care is tea and toast with a senior citizen, and it's far from that. There's chemo being done, extreme wound management, IV therapies, like the list is so long. It's such a complex service now that it's what was previously done in acute care is being done in people's homes. So again, I think we just have to focus a little bit on what kind of value statement are we going to say for home and community care support services or support, sorry.
Yeah, there's quite a number of questions that have come in from the audience members about the health human resources challenges in home care. Questions, do we have enough people coming into the sector? Is this primarily a recruitment problem? Is it a retention problem that you spoke to, Connie, about people leaving for greener pastures because they're paid relatively poorly compared to other parts of the system? What's your assessment from a provider perspective here, about the short and longer term outlook for health human resources? Are you and your colleagues going to have the people to meet this need in the current system?
Well, that's a great question. I really want to be optimistic, Dan, and I'm trying my best in my gray matter right now. But unless we value all parts of the system equitably, then one part of the system is going to fail. And unfortunately, we have seen home and community care support services underfunded for almost 2 decades. And the fallout from that, along with service cuts during COVID, was catastrophic for the home and community care services. And it's very difficult because the narrative is to blame the service providers, but in actual fact, we need to look at the system as a whole and treat people with the respect that they deserve and the respect for the value of their role in the community. So yeah, I think it's going to, unless we address the inequities, we need to, it's going to just be catastrophic within the home care system. And I'm not a fear monger, but I have to say after the weekend, I became extremely nervous that this is just one more thing that home and community care is going to have to deal with that may be the final straw that breaks the camel's back.
Yeah, well, Laura spoke to the change in British Columbia 20 years ago. That I can't remember the exact costing on that, but it was a few $100 million, I thought, in terms of harmonization across the healthcare system. I know Ontario has looked at it over the years. The Ministry of Finance has pulled projections because there are people that recognize that this is a huge impediment to system integration and performance in home and community care. And every time people look at the price tag of what it takes, they say, we can't justify it now. And I wonder when it's going to get to the point where we say the system is so fundamentally not functioning as a system because we have these incredibly discriminatory and differential pay rates across the different sectors, that there will be some commitment to address that over time. And it's undoubtedly a lot of money that will need to be sunk into the system to address that and promote a more equitable framework.
I'm not a fearmonger. I'm not a fearmonger at all, but I can tell you, just look at the demography. The answer is no, we don't have enough people, and we need to be dealing with this much better. Like the sheer numbers in reality is we also need people to work in the system longer. So we need.
Oops, Laura's frozen, I think.
Well,
Deborah, do you want to jump in?
I just want to say to Connie's point, it's not only catastrophic for the home and community care system, it is catastrophic for the entire system. If we fail as a system in home and community care, the entire healthcare system falls on this. There is not the ability to be able to provide the level of care across the entire system without home and community care as part of the solution. We don't have the funding to do it. We're already hearing the demands from the public that they don't want to be in long-term care facilities, so we're going to get that pushback on it. So it is a failure of the entire system. And we've already, before the pandemic, we had already seen ALC numbers skyrocketing, in Ontario over 5,000. As we went through the pandemic, of course, it only got worse. And we're now trying to deal with that backlog with a broken system that does not focus on getting people into where they need to be right now in terms of supporting the capacity for home and community care to be able to support some of those people who should be in the community and not necessarily in long-term care. So it is a system failure, not necessary. And I don't think we can afford not to do it. We'll just pay it in a different way.
Sorry, I was on mute. There's some questions in the chat about, how much is technology going to address this human resource crisis? And I guess the question is, does technology mitigate this need to address the structural issues around compensation? Is that an answer, or is it no? You need to do both. Laura, you want to jump back in?
No, I mean, these are ands, right? I mean, I want us to think about solutions, right? So there's a couple of things that we need to do. The first is we need to understand that we're going to have people do more.
Oops, I think we've lost her again. So I'll go to Connie. I don't know if you want to comment on the technology piece complementing human resources to think about how you're going to maximize productivity.
I think it is one solution because we provide services across some really quite remote geographies where, in fact, there's not enough work to even employ a full-time clinician. So if we just talk about speech pathology, we have been requesting pre-pandemic to be able to provide some virtual care because we have been trying to recruit a speech pathologist for almost 2 years, I believe, and that was declined. However, when the pandemic came along, we were able to do that. So we had people going without services, and then all of a sudden they got services because virtual was acceptable. So I think it's going to be all of the above. And when we talk about technology, I think it's really important that as we move forward, we need to acknowledge that all clinicians need to speak with one another. So we must be having acute care, being able to speak with home care, to speak with community and social services, long-term care, and primary care. I can tell you when Closing the Gap first came to be, we provided reports to all those people using NCR reports. We don't have that ability to speak to everybody across the healthcare system. And now we see many organizations have purchased different systems, but there's no interface. So we can all look at the same chart and the same information in a timely manner. I'll pass it back to Laura.
I think Laura's still having some technical
I would just to answer your question, Dan, I think clearly we need both. I think, if you look at the percentage of the type of care that's delivered in home and community care, it's primarily personal care. And personal care can be augmented by technology. There's technology to weigh whether or not the continence device that you have on somebody is in need of change. There's communication, but absolutely you're still going to need the physical care that is provided primarily by personal support workers to be able to have a robust home community system. So I think we can't ignore this. I know in our previous 3 years ago in our pre-budget, we suggested on the wage parity that there be a much more stepwise approach to parity, that we could move this forward in such a way. But of course, we went through a period of time where we weren't able to move wages, and so we really do have an issue on our hands now. But there's no doubt that we need both technology and human resources to solve the issues of capacity.
There's one question or a series of threads that have come in that I just like. We've spoken a lot about the system impediments and what needs to change from the system perspective. There's some questions here on the provider and the staff perspective. What should we be expecting more in terms of accountability, transparency, and performance from home care providers and staff? Like how should we judge the impact of providers more effectively if we're going to be significantly investing in home and community care services? Connie?
Okay, so I'm a fan of public reporting. I'm a fan of the hospital report cards that we used to have, and I can't see why we wouldn't want, using public funds, why we wouldn't support public reporting and the accountability metrics put in place. But what I don't support are all these process metrics that are punitive. What we need to focus on is patient outcomes, and how do we implement the quality standards that have been created from the former HQO, and make sure that people have access to what is considered best practice and the patient tools. What I also want to say is, it's not all doom and gloom out there, and I know we're running out of time, but there are so many fabulous innovations that are out there, that our funders are supporting, that hospitals are supporting, working closer with home and community care. And I don't want to overshadow that by what's wrong, because I think we can always find things that are wrong. I think that's part of human nature, but there are so many positive innovations that have moved forward in the last year that I'm incredibly proud of.
Yeah, I think that was actually, if we look at some of the positive things that actually came out of the pandemic, it really pushed technology right up the totem pole in terms of opportunities and the ability to put those in place really quickly. It also really tightened up where there were relationships, really the integration between home and community care, hospitals and long-term care. I mean, we worked incredibly tirelessly together. So I think, there are, we know each other better as a health system. I think that has definitely been one of the pluses. And I think we can just build on this moving forward. As Connie says, it is just look at what has been achieved and then, minimize what doesn't work and try and address those as we integrate the system.
I think I'd like to have each of us wrap up on this kind of positive future-looking perspective, where one of the questions has been, if you could do one thing, if you could change one thing, if you could build on one innovation, if you could take one thing from a learning from another jurisdiction that you'd want to see adopted across Canada, what would that be? Where should Laura? I'll start with you.
Okay. Equal pay and benefits, and having it the same as in acute care. It doesn't matter what we do unless we actually address the structural issue of payment. We'll never get anywhere. I'm going to sneak one extra thing in, though. We actually need to understand that about 75% of care is actually provided for free by family and friends. And we need to upskill them. We don't provide any training or support. It happens episodically, but we actually need to be thinking about how professionals can help to train and support the unpaid non-professional carers who are in fact the bulk of what care is happening at.
Thank you very much for bringing that up. Yeah, we did not talk that much about caregivers. We talked about technology expanding the reach of paid health human resources. Obviously, caregivers is and volunteers in the community sector, massive pieces that we can tap into. Connie, your kind of key takeaway of where we can build on those green shoots of progress and what we need to do next.
Yes, I'm really quite excited to watch how we evolve and how we build on the fact that clinicians are the best experts to make decisions in harmony with their patients and families on the best path forward for care, and to remove the barriers and respect that clinical patient relationship.
Thank you. Deborah, final word.
Oh, thank you. I never get that. So that's so great. So no more best kept secrets. Home and community care, community first approach has to be topmost in the minds of our decision makers. Healthcare system cannot thrive and move forward, whether it be in integrated models anywhere without the inclusion of home and community care as one of the key components of the healthcare system.
Thanks very much, and thank you for all that have joined us. There were some additional questions that were sent to us. Those of you who have left your name, if we have your registration information, we'll try and get the panelists to respond to some of these questions, and we'll mail you the answer. Apologies that we didn't have time to get to everything. We had a very engaged audience for this group. It was fantastic. And thank you again to our panelists. This has been wonderful to participate in.